Micro CT is not a new technology, and it's been used in research and engineering. Micro CT in dentistry has been used only in the research field. The major difference between the clinical and micro CT are its size in field of view and resolution. Micro CT typically has a very small field of view, but its resolution is much higher than that of clinical CT. It's regarded as a state-of-the-art research tool, but no one really thought about its clinical implications up until recently. In dental industry, major companies all rushed into developing intraoral scanners. However, as far as I know, there are no intraoral scanners accurate enough for full arch implant cases. There are distortions on all X, Y, Z axes, especially when two scanning objects are apart more than 20 millimeters. This happens very frequently in full arch implant cases, and according to scientific literatures, no intraoral scanners are suitable for undertaking extensive implant cases. Intraoral scanners work very well for smaller cases such as quadrant or less cases. I've seen some brave doctors who used intraoral scanners to do full arch cases and failed. And their failure involved open margin, ill-fitting restoration, which led to fracture of the bridge or frequent debonding of the titanium bases. We brought micro CT scan technology to our laboratory since 2018, and we're scanning all the extensive cases using micro CT scan. The result was phenomenal. Personally, as a prosthodontist, I do a lot of full arch or full mouth cases, and such extensive cases were all done using micro CT scan, and I always find the restorations fit with precision and accuracy. Implant dentists all know very well about how to connect implant coping into implants, and I believe that we have no problem of correctly connecting the scan bodies into the implant. Not all dentists know how to use intraoral scanners properly, but they all know how to take accurate impression. Therefore, I recommend simply taking the impression over the scan bodies, and we can digitize the impression using the highest resolution micro CT scan. Then we can bypass the plaster steps and perform the most accurate full digital and modeless workflow. And we can come up with the most accurate and precisely fitting restoration of any extent. In dental laboratory, prostheses are manufactured after multiple steps, and out of all the steps, I think the most errors come from the plaster work. The plaster work may become inaccurate from die stone expansion, fracture of the model, tear of the impression, and most importantly and most frequently, wrongful insertion of the transfer coping into the impression. In typical dental laboratory setting, this important and the most crucial step is usually handled by the most inexperienced technicians. That's the reality. Therefore, dental industries were all rushing into developing digital workflow to bypass this plaster work. But it did not work very well with intraoral scanners.